Welcome back to our series, 50 Studies Every Neonatologist Should Know. Today, we're looking at study number 3, the HeLP trial, HeLP standing for Heat Loss Prevention. This was a large, multi-center randomized trial asking a deceptively simple question. If we wrap our most fragile, extremely preterm babies in plastic right after birth, do we actually save lives? It's a great example of how a sensible, physiologically appealing intervention behaves when it finally gets tested in a properly powered study. So let's dig in. Before we get into the numbers, I want to start with the trialists' own words, because they capture the central tension of this study. They acknowledged that even though the trial found no overall mortality difference, it simply wasn't powered to detect a benefit within each gestational age subgroup. In other words, for the very smallest babies, those below 26 weeks, they couldn't be certain there was no life-saving benefit hiding in the data. That honesty matters. It tells you this is a careful trial that resisted overclaiming, and it sets up everything we'll discuss about what a null result really means. Let's look at the question they set out to answer. Here's the question in clean PICO form. The population is extremely preterm infants, between 24 and 27 weeks of gestation. The intervention is a polyethylene occlusive wrap, essentially a plastic wrap applied right at delivery. The comparison is conventional care, drying the baby and standard thermal management without a wrap. And critically, the outcome here is not just temperature. The primary outcome is all-cause mortality, measured up to hospital discharge or 6 months corrected age. That's an ambitious endpoint, because most prior work had only shown the wrap improves temperature. This trial wanted to know whether that temperature benefit actually translates into survival. Let's see why that mattered. So why do this study at all? The logic chain was compelling. First, hypothermia is genuinely dangerous. For these tiny, immature babies, a cold body temperature is associated with higher mortality. Second, we know plastic wrap works mechanically. It cuts down evaporative heat loss in those critical first minutes. Third, 2 earlier small trials from this very group had hinted at not just warmer babies, but actually fewer deaths. That's exciting. But, and this is the key, when you pooled all the small studies together in meta-analysis, the result for death remained inconclusive. Small trials are prone to inflated effects. The field needed a large, definitive trial to settle whether the survival signal was real. That's exactly what HeLP set out to do. Let's look at how it was built. Let's get the design straight. This trial ran a long time. Enrollment began in 2004, and it was finally published in 2015. It was a big international effort. 39 centers across 7 countries, including the US, Canada, Spain, Portugal, Singapore, Ireland, and Malaysia. The design was a parallel group unmasked randomized controlled trial. Now, unmasked is important, and we'll come back to it. You obviously can't hide whether a baby is wrapped in plastic. Randomization was stratified by site and by gestational age, splitting infants into a 24 to 25 week group and a 26 to 27 week group. And here's the number to hold on to. 801 infants were ultimately analyzed. Keep that figure in mind, because the trial... Who was studied? The trial enrolled infants between 24 and 0.7 and 27 and 6/7 weeks gestation, so the most extremely preterm population. There was one important practical criterion. There had to be a firm decision before birth to provide full resuscitation. That makes sense. You only enroll babies you actually intend to treat actively. On the exclusion side, they left out infants with major congenital anomalies, where the skin isn't intact, like gastroschisis or meningomyelocele, because a wrap doesn't make sense there. They also excluded babies with blistering skin conditions, where applying an occlusive wrap could cause harm. So this is a clean, sensible population of the babies most likely to benefit from heat conservation. Now, let's see what was found. The intervention itself was straightforward. After randomization, babies in the intervention arm got a polyethylene occlusive wrap placed immediately after birth, before they were even dried in the usual way. That wrap stayed on until the infant was admitted and stabilized in a thermoneutral environment, basically until they were warm and settled in the NICU. The control arm received routine care, standard drying and warming, but no wrap. So this is a clean head-to-head comparison of wrap versus usual practice. One thing to flag now, which becomes relevant later. Because you can see the plastic, neither the caregivers nor the team could be blinded to which arm a baby was in. Hold that thought. Let's look at what they measured. Now the endpoints. The primary outcome, the one the whole trial was built and powered around, was all-cause mortality, measured up to discharge or 6 months corrected age. That's deliberately a hard, patient-centered outcome. The secondary outcomes are where you see the more familiar measures. They tracked axillary temperature after stabilization. That's the direct test of whether the wrap actually keeps babies warmer. They looked at APGAR scores, and they recorded the common complications of prematurity: patent ductus arteriosus, or PDA, pulmonary hemorrhage, and intraventricular hemorrhage, or IVH, bleeding in the brain. Keep the distinction clear in your mind. Temperature is a secondary outcome. Survival is primary. That framing is everything when we read the results, which we'll do now. Here are the headline numbers. The primary result first. Death rates were essentially identical, 20.5% in the wrap group versus 20% in controls. The odds ratio was 1.0, with a confidence interval from 0.7 to 1.5, and a p-value of 0.85. That is a textbook null result, no mortality benefit. Second, the mechanism barely moved. The wrap raised temperature by just 0.6 degrees Celsius, a surprisingly modest gain. Among secondary outcomes, the picture was mixed. Wrapped babies had a lower 1-minute APGAR score, but also less pulmonary hemorrhage. And intriguingly, in the smallest stratum, 24 to 25 weeks, there were signals of less treated PDA and less pulmonary hemorrhage. Sometimes a picture makes the point better than a table. Here are the two mortality rates side by side: 20.5% in the wrap arm, 20% in standard care. Visually, the bars are virtually the same height, and that's the entire story of the primary outcome. The call-out on the right gives you the statistics: an odds ratio of 1.0, confidence interval 0.7 to 1.5, p equals 0.85. When the confidence interval comfortably straddles 1 and the point estimate sits right on it, you're looking at no detectable effect. After more than a decade of enrollment, the wrap did not change survival. So the obvious next question is, can we trust this null result? Let's appraise the trial's weaknesses. Every trial has weaknesses, and HeLP has several worth knowing. First, it was unmasked. Caregivers could see who was wrapped, which opens the door to performance and detection bias in how babies were managed and assessed. Second, and this is big, the trial was stopped early for futility. It enrolled only 801 of a planned 1,604 infants. That under-enrollment means it was underpowered, especially to detect effects within the gestational age subgroups. Third, there were frequent protocol violations in correctly placing the wrap, which likely diluted any true effect. Fourth, the mechanism itself was weak, only 0.6 degrees of warming. And fifth, most families consented antenatally, and women who can be approached for consent before an extremely... So where did the evidence go from here? A large Cochrane meta-analysis by McCall and colleagues in 2018 pulled together 25 studies. Its conclusion echoed HeLP. Plastic wraps and bags reliably reduce hypothermia, but there's limited evidence they improve any short-term morbidity or survival. The authors floated an important idea, that hypothermia might be a marker of how sick a baby is, rather than a direct cause of bad outcomes. That reframing helps explain why warming the baby didn't rescue survival. There's also a birth weight signal. A smaller, earlier trial got bigger temperature gains in the tiniest infants, under 750 grams. And importantly, guidelines never wavered. The American Academy of Pediatrics recommended polyethylene bags for babies under... Let's bring it home with the clinical takeaways. First, the HeLP trial confirmed beyond doubt that occlusive wrap reduces hypothermia in extremely preterm infants. That part works. Second, and most importantly, it did not reduce mortality. The warmer temperature simply did not translate into more babies surviving, which is a humbling lesson about assuming that fixing a risk factor fixes outcomes. Third, the trial reinforced that the wrap is safe and useful for thermal control. And fourth, despite the null mortality result, guidelines worldwide continue to recommend wrap because it's inexpensive, simple, and effective at what it actually does, keeping babies warm. As the editor Roger Soule noted, a larger study often fails to confirm the early promise of small trials, but a cheap, safe Finally, the key references for anyone who wants to read further. The primary citation is Riley and colleagues in the Journal of Pediatrics, 2015. That's the HeLP trial itself. The earlier Vora pilot work and the Kramer systematic review give you the backstory. The McCall-Cochrane review from 2018 is the best synthesis of the broader evidence, and the Vora consent analysis from 2021 is worth a look for the generalizability question. And the 2020 International Consensus Guidelines confirm that wrap remains standard delivery room care. Thanks for watching this episode of 50 Studies Every Neonatologist Should Know. I'll see you in the next one.